We present a case of a 42-year-old keratoconic woman who was intolerant of her contact lenses and chose to undergo corneal transplantation. You see that we are trephining at 300 micrometers using a Hesberg-Baron 8mm trephine. Our first attempt at a big bubble fails and we only get surgical emphysema. We then used the 27 gauge bent needle at a different location to perform pneumodissection, and on this second attempt you can see that we managed to get big bubble separation of the stroma from the Descemet's membrane. You can see that a type 2 bubble is formed, and this is clear because in slow motion replay you can see the bubble forms from periphery to center and has a very clear edge to it. We then make a temporal paracentesis and a small bubble of air injected into the anterior chamber to aid in confirming the presence of a big bubble. Radial markers are made and some viscoelastic laid on top of the cornea before the stab incision. This is performed using a 15-degree blade, and with a swift movement we are able to gain access into the pneumodissected plane. Vanna scissors are then used to separate the corneal stroma from the underlying layers. Extreme caution is taken in these maneuvers to avoid inadvertent perforation of this type 2 bubble, which, as we know, has far less biomechanical strength and is far more fragile compared to a type 1 bubble. With careful maneuvers and after taking a considerable period of time to remove the stromal tissue, we are able to achieve a nice surgical plane and bear Descemet's membrane. The presence of the bubble in the anterior chamber is a useful guide to help the surgeon in verifying the intact nature of Descemet's membrane during these tissue manipulations. Once Descemet's membrane is bared, we then perform irrigation of the surgical interface to remove all remaining viscoelastic material in order to avoid complications such as pseudo-double anterior chamber post-operatively. So generous irrigation of the surgical bed is performed. During irrigation, however, you can see a macro perforation of the membrane occurs, which is a highly unusual phenomenon. In slow motion, you can see the bubble clearly escaping from the anterior chamber. And fortunately, at this stage, we had not removed the endothelial layer from the donor lenticule, which is something we routinely perform, as it's been shown to provide some advantages both visually and in terms of wound healing properties. You can see that there's no way to rescue this perforation, as the entire Descemet's membrane has effectively dehisced. Viscoelastic material is placed on the bed, and a full thickness donor lenticule is then secured using 16 interrupted 10-0 nylon monofilament sutures. The patient had an uneventful recovery period and was pleased with the final outcome. However, this video acts as a reminder of how fragile a type 2 bubble can be and highlights the importance of exercising extreme caution in performing all surgical maneuvers, including irrigation of the surgical interface. We now advocate leaving the endothelial layer intact on the donor lenticule in cases where a type 2 bubble has been achieved during pneumodissection, as the incidence of a perforation can be as high as 80% in some of the reported literature. Thank you.